why this started back in 2015, I'm sorry. Any takers as to why you think this happened, this third wave of when this became an epidemic and the nation really said that this was an epidemic? Anybody want to put it in the chat why this started? Well, this is when fentanyl was introduced into the public. So now we have this substance that is about 100 times stronger than heroin, about 10 times stronger than morphine, and it comes into the public, and we have these people just using it, not knowing what's in it, and dying from this. And this is where the third wave of the opioid overdose happened, and where we started to lose a lot of more people. So in since this happened since 1990 until 2016, fentanyl tripled the amount of overdose deaths. And so this is when the nation said, this is something's going on here. What's going on here? Why are these deaths happening? And this is when it became an epidemic. Thus, this is why we call it the Heroin Epidemic Relief Organization. As you can see, the sign is behind me. So there was opioid overdose is the leading cause of accidental death in the U.S. And there's some stats there from the CDC. In particular, here in Will County, this is where I live, so I got these numbers from Will County. In 2022, the Will County Coroner's Office reported 112 heroin or fentanyl overdose cases, and 3 out of 4 new heroin users reported misusing prescription opioid prior to heroin. So a lot of times I like to stop here and just pause and say that I was one of those. I was one of those 3 out of 4 new heroin users. I was a registered nurse for 16 years, and I started in misusing opioids. And when I no longer had access to those opioids, I did resort to heroin because it was readily accessible. It was cheap. It was around the corner. I thought at the time that I needed to do for my family. So I thought that was the best solution at that time. And this is what most people who are addicted are thinking. They're not thinking of like, this is harmful, this is wrong, this is going to give me negative consequences. We're not thinking that. We're just, I don't want to feel pain. I don't want to be anxious. I don't want to be depressed. I don't want to feel like I'm dying. I need to work for my family. I need to do this for XYZ. And so we resort to the next best thing that we think is needed at that time. And yes, like I said, most heroin users don't start out with heroin, don't start out with right away doing it. A lot of them, 3 out of 4 are those who misuse prescription opioids. So just think about that. Here's a map that shows from 1999 to 2015 what the heroin or the fentanyl overdose deaths, how it just engulfed the whole United States. You can see where it starts off in the coasts and then kind of gathers more towards the center, the central US, and then it just kind of overtakes the whole United States. So it gives you an idea of how it started and how it just over these years just kind of took over. So this is what we're seeing nowadays. Okay. Now I'm going to play a video here. Let me just bring it up. It's a video that talks about addiction and what addiction is and what it does. So I will
Addiction is
share this.
defined as not having control over doing, taking, using something to the point where it could be harmful to you. Previous to understanding the science, it was thought that addiction resulted from a lack of willpower and was a moral failing. But we now know that addiction is a physiological disease. It changes the brain structure in ways that can alter the way it works and process information. To understand how that happens, we start by thinking about reward and the brain's natural reward system. The reward pathway's primary function is to reinforce sets of behaviors. Evolutionarily, it began as a way to indicate to us that actions that help us survive are good and we should keep doing them. This is mediated through a chemical called dopamine. Following an appropriate behavior, the reward pathway releases a small burst of dopamine. That burst of dopamine is a satisfying jolt, encouraging you to repeat the same action in the future. Dopamine will in turn also act on areas responsible for memory and movement, which helps us automatically build up memories for what is good for survival. The problem is that addictive substances hijack our natural reward system. Every substance has slightly different actions on the brain, but one thing all addictive drugs have in common is that they produce a pleasurable surge of dopamine. Addictive drugs all cause dopamine to flood the reward pathway 10 times higher than a natural reward would. Over chronic use, nothing else natural is quite as rewarding. In fact, as substance use increases, the circuits adapt and reduce their sensitivity to dopamine, a phenomenon known as tolerance. For example, let's say a person takes cocaine for the first time. The reward system receives a huge burst of dopamine. But as the person takes more frequently, cocaine will be overstimulating the brain with dopamine. This will cause the brain to adapt to these chronically high levels of dopamine. To compensate and adapt to this new normal, the brain reduces the number of dopamine receptors available in the reward system and releases less dopamine. As a result, that person will feel the need to increase the amount of drug they take so that they can reach the level of high that they're used to. But it's not just the reward system that's affected by this tolerance, since dopamine is also involved in other brain mechanisms. Other brain regions involving decision-making, memory, and judgment also get physically disrupted as a result. The overall effect is to have drug-seeking behavior driven by habit rather than conscious thought, like a reflex instead of a choice. This biological basis helps to explain why addiction really is a brain disease, not a matter of willpower. The stigma that accompanies addiction only makes seeking treatment more difficult.
Okay, so that was addiction in a nutshell. I know that Celeste said to make the slides bigger. Let me know if that's any better. All right, so that's addiction in a nutshell. So what is an overdose? So an opioid overdose can occur over time. It can happen within an hour, within 3 hours of ingesting a large sum of drugs. And normally what happens is that the respiration is suppressed and the person stops breathing. We saw in that particular video that there's opioid receptors. And when the opioid goes into those receptors in the brain, that's how an overdose happens. Those receptors get overwhelmed. So there's more opioids going in there, more and more and more, to where the brain is unable to properly breathe, right? Things start shutting down. So we start losing consciousness and we start not being able to breathe correctly. And then again, until we stop breathing. And we don't die because we are unable to stay conscious or we're not able to move, or no, we die because of the lack of oxygen. So once we stop breathing, the lack of oxygen is what kills the person, right? Because there's no more oxygen, and then the brain either has a stroke, or the heart can have a heart attack, or those things are is what really happens, is that there's a lack of oxygen that happens as a result of those opioid receptors being overwhelmed. And taking more opioids than prescribed can contribute to this overdose. Combining opioids with other depressants, such as alcohol, can also increase the chance of having an overdose. And taking more opioids than one can tolerate definitely increases that chance. I always, when that word tolerate comes up, I always stop and just think about the tolerance, right? If my child plays baseball and my child breaks a bone, a leg, or an arm playing baseball, we take him to the emergency room and he needs surgery and he is prescribed an opioid because we don't want him in pain. We don't know what his tolerance is. We don't know if he can take opioids. We don't know if he's allergic to opioids. We don't know anything because it's never been introduced in his body. So, should you have Narcan available? Absolutely. Anybody that has been prescribed an opioid, anybody that knows of anybody that's using drugs or medications or just having it around. And even I always say, because I have a lot of people telling me, well, I don't know anybody that uses drugs. I don't know anybody that's been prescribed an opioid. Why do I need to have it around? It's like CPR. It's better to have it and not need it than to need it and not have it. And so I always just say, just have it. It's free. You're not paying anything for it. But guess what? If you need it, you have it and you can save a life. So it's better to have it and not need it. So tolerance, same thing with my, if my grandma falls, breaks a hip, now has hip replacement. We don't know what her tolerance is. We don't know if she's ever taken opioids before, if she's currently taking opioids, right? She may be taking something that she doesn't even know it's an opioid. And mixing those two can cause a potential overdose. If she's already taking tramadol, I know that back in the day they thought that tramadol was not an opioid, so they wouldn't take it or categorize it like an opioid. So some people would say, "Yeah, I'm not taking any opioids," but tramadol is an opioid. It does increase the chances of overdosing. So if she's taking something and unfortunately with our elders, they take so many medications and sometimes it's hard to even see what's being taken, what's been discontinued, what are they still taking, what are they not taking anymore. So they're at a higher rate of overdosing. So they should have they should have Narcan available if they're taking any of these opioids at all. So again, I go back to this as well. Addiction is a treatable condition. We saw that video. We saw that it's not about willpower. It's not about being able to stop when I want to or start when I want to or start. None of that. It's not about willpower. It's a mental disease. It's considered a mental illness by the DSM-5, and it is now a co-occurrent disorder, right? Because they're saying that addiction goes together with mental illness and vice versa. So it is a treatable condition. It does not discriminate. It doesn't care if you're white, if you're black, if you're Hispanic. It doesn't care what kind of car you drive, what kind of house you live in. It doesn't care what kind of education you have. It doesn't care how many zeros you have in your bank account. It doesn't care. So it's gonna affect anybody the same way it affects anybody in the on the other side of the globe, right? It's not gonna discriminate. And so I always say that we have to be empathetic to those who are going through addiction or have gone through addiction because it's a hard journey. I myself, I'm a person with lived experience. I've gone through this journey and it's hard. It's not easy. It's very, very hard. It's doable. I always tell people you can do it. It's very doable. There's plenty of resources out there. There's plenty of opportunities to be able to recover, but it's definitely hard. And we just have to empathize with them and sympathize with them as well because it's harder if I have people putting me down. If I have people encouraging me and people cheering me on that I can do this, it's going to be a lot easier than if I have people telling me that I'm a junkie, that I am no good. Why can't you do this? I don't understand why it's so hard for you. All those things really hurt. And if we encourage rather than dismiss or diminish, I think it just provides a healthier, healing environment. How does overdose work? So, like I said earlier, what happens is that those receptors are overwhelmed with the opioids until the breathing starts to slow down and then eventually it stops. And the lack of oxygen is what causes brain damage, the heart to stop, seizures, stroke, and eventually death. And we also talked about what increases an overdose, right? So we talked about mixing opioids, so making sure that we know what medications we're taking. Other sedative substances such as benzodiazepines, well, what are those? Those are your Xanax, your lorazepams. I know on the streets they call them Xans or they call them footballs. And so mixing those two increases the chances of having an overdose. And also alcohol, because alcohol is a depressant and it increases the chances of having an overdose. Recent release from incarceration or detoxification program. I personally, when I started my recovery journey back in May of 2021, and up till I stopped counting in October of 2022. But from May of 2021 to October of 2022, I personally had 23 people die of a drug overdose. And most of them, I would have to say about n- good 90th percentile, but I don't know exactly how many of them, but most of them were because they would go to treatment and say, I'm ready for treatment, I'm ready to recover, and stay there for 2 or 3 days, maybe a week, maybe a couple weeks, and then leave. And they would go back to the streets and think that they can use the same amount of drugs that they were using when they went into treatment. Same thing with incarceration. People would get picked up for a warrant, or the judge would put them into custody, or they'd get rearrested for something else and they'd go in jail. They'd stay there for a day, a couple days, a couple weeks, a couple months sometimes, and then they would come out thinking they can use the same amount of drugs that they did when they went in. And unfortunately, the tolerance that we were talking about, the minute that I stop using drugs is the minute that my tolerance starts lowering. So I have a really low tolerance for drugs when I come out of a detoxification program or incarceration. So the tolerance lowers, people go back out there and use the same amount. Guess what? Now you're overflowing these receptors with opioids, and unfortunately, a lot of them did pass away. Other conditions such as COPD, asthma, depression, or anxiety, these other conditions can also interfere and increase the risk of an overdose. And like I mentioned before, having no tolerance, such as children and someone who has never used opioids before. Um, Children, when I see that word children, I was just talking about this last night at another meeting that there was a 2-year-old that passed away from a drug overdose. And this was last year, about a year ago now. And the parents were using. Kids don't know what the difference is between a pill and a piece of candy. And unfortunately, these two little girls ingested drugs, and the youngest one, the 2-year-old, started to overdose. And the parents did have Narcan in the house, but they were spraying her face with it instead of inserting it in her nostril and really getting the medication in the system. Parents were freaking out. They had drugs in the house, they had paraphernalia in the house, they were both using, so they didn't wanna call 911, and this little girl, over the course of about 4 hours, did end up dying because the parents did not know how to use Narcan properly, and this is why I say, yes, it's great having it, it's great carrying it, thank you, but let's also educate people, let's also learn how to properly use it, because if I'm not using it properly, then it's not gonna work. So someone who doesn't have or has a low tolerance or has never used an opioid before is at a higher risk of overdosing than anybody who ever has. So how do we know when somebody's overdosing or if somebody's really, really high? So here's a graph that I show, and it really comes down to one particular thing that I'll talk about in a minute. But when somebody's really high, their muscles become really relaxed, their speech is slowed or slurred, they're sleepy looking, their heart rate is normal, their pulse may be normal, and their skin tone is okay, it's normal. When somebody is uh, really like when somebody is experiencing an overdose, their breathing is infrequent or has stopped. they can be snoring or having that gurgle. It's called a death rattle. It's because the secretions are unable to come out of the lungs or get stuck in the, in the esophagus. So it makes this noise like a gurgling noise. Uh, their heart rate is slow or their pulse is slow. It's may have stopped. Their lips are blue or their face starts turning blue. And this is because, remember, the oxygen that supplies our body to be alive is decreasing because our breathing is slowing. So there's no more oxygen going to our body. So my body wants to keep me alive. And the most vital organs that I need to stay alive is my brain, my heart, and my lungs. I can be alive without a leg. I can stay alive without an arm or a finger, but I cannot survive if I don't have lungs, if I don't have a heart, and if I don't have a brain. So what my body does is when it knows that something's going on and there's a lack of oxygen and I can't get oxygen, the first thing that it's going to do, it's going to send all the oxygen to my brain, my heart, and my lungs. So guess what? My lips are going to be blue because there's no oxygen going there. My toes and my fingers are going to be blue because there's no oxygen there. So when you do a capillary refill, you're not going to see any return there because all the oxygen is being sent to my vital organs. So this is a really, when I see somebody with blue lips, I know that it's a crisis and I need to act fast because the oxygen is no longer going there. However, the most important thing that I want you to take away from this is the responsive to sternal rub, shouting, earlobe, or pinch. When they're unresponsive to that, this is very crucial. A sternal rub is very, very painful. So a sternal rub is when you take your knuckles and you rub them in the middle of the sternum, which is the middle of the chest. And when you do that, it's very, very painful. If you try to do it to somebody who's awake and alert, they're going to push you away because it's painful. If you're trying to do that to somebody who's overdosing and they're not pushing you or they're not waking up or they're not at least telling you get away, chances are they're overdosing because it's very painful. And normally somebody is going to be responsive to that. When I um, overdosed, I had the sternal rub done to my sternum, done to me on my sternum, and I was unresponsive. So I was Narcan, and thank God I was brought back to life. But I don't recall the sternal rub. But I do recall the next morning waking up with bruises and a painful, painful chest because it is a very painful thing to do for somebody. So if they're unresponsive, they're probably overdosing. So, what are we going to do now that we've identified an overdose? We are going to call 911 first and foremost. Everybody has a cell phone. Everybody can call 911 and put it on speaker and put the phone next to you on the side of you and start doing the rest, right? So we've recognized somebody's overdosing. We've done the sternal rub and now we've called 911. The next thing we're going to do is we're going to administer naloxone and do rescue breathings if comfortable. We're also going to stay until help arrives, and I'll explain a little bit more about that in a minute. So why naloxone? Naloxone is very safe. It's as soluble as water. It is not going to hurt anybody if they have not taken any opioids. So the only thing that the naloxone is going to work on is on opioid receptors. My body wants this medication more than it wants opioids. So what it's going to do when this medication is introduced into my body, it's going to kick out those opioids out of the receptor and it's going to put naloxone in there. But remember, naloxone is safe. It's like water, so it's not going to do anything to me. It's just going to kick out the opioids so that it reverses the overdose, and so I can start breathing and come back to life. There's no potential misuse or addiction and it will not hurt anybody. Like I said, I'm diabetic. If I pass out and people may think that I'm overdosing and they give me naloxone, but it turns out that I didn't eat anything and I took too much insulin. Well, now I am passed out because my sugar is very low, right? Hypoglycemia. So if somebody gives me naloxone, it's not going to hurt me. It's not going to take care of my hypoglycemia, If I'm having a heart attack, it's not going to take care of my heart attack. If I'm having a stroke, it's not going to take care of my stroke, but it is going to reverse the overdose. And if that's why I passed out, that I'm going to be able to come to. So how to give nasal spray naloxone. We're going to peel back the tab, remove the Narcan from its package. We're going to place the device into one nostril. We're going to place the plunger firmly. And then again, we're going to get emergency help right away. I am going to play a video so you guys can see it. It's a quick video. Give me 1 second. And it'll show you exactly what to do in a more detailed description that I can tell you with words. Let's see, here it is. Okay. Hold on 1 second. I think I pressed. I'm gonna rewind it real quick because I think we missed it. There it is. Okay.
911, what's your emergency?
So you peel it back. You insert it into the nose, all the way in. Okay. And you're gonna push the plunger. You're gonna hear that noise. You're gonna wait 1 to 2 minutes for it to respond. And that's what we're gonna talk about now is those 1 to 2 minutes. So we're gonna pull that, again, we're gonna pull it, we're gonna pull the plunger out of there. We are going to insert it and hold on 1 second. I don't know if here it goes. And then we're gonna spray and wait 1 to 2 minutes. If the person is still unresponsive after those 1 to 2 minutes, we're gonna reassess again. So we're gonna wait oh, it says here 2 to 3 minutes. I say 1 to 2 minutes, but 2 to 3 minutes, 1 to 3 minutes. It's a long time. It seems like forever when you're waiting there. 10 seconds seems like forever. 30 seconds seems like forever. So 2 to 3 minutes can seem like a long time, but while you're waiting there, if the person's not breathing, you can give rescue breaths if you're comfortable. But you reassess. The person is still not coming to. The person is still unresponsive. So what we're going to do is we're going to give a second dose of naloxone on the opposite side, on the opposite nostril. And then we're going to start the whole process all over again. We're going to reassess every 2 to 3 minutes and keep doing that. You can do it as many times as you want. I've known somebody who was Narcan 7 times. So 7 doses, 7 sprays, and he still wasn't coming to until the paramedics came and took him. So you can keep on doing this until help gets there. Okay, here, that was the video. So rescue breathing. I always say if you feel comfortable doing rescue breathing, by all means, please do it. If you're CPR certified, please go ahead and start that process. But it's up to you. It's up to the person's discretion. I always say if you don't feel comfortable because you don't know the person, we all have t-shirts on. We can just put a t-shirt over their mouth and do rescue breathing if that makes you a little bit more comfortable. So we're going to check that the person's airway is clear. We don't ever want to put our fingers or something in their mouth to try to get it out because that can put the item more into the airway. So if you can see it and you can grab it with 2 fingers from the outside of their mouth, great. But if not, do not stick anything in their mouth because it'll push the item further down their airway. We're going to place one hand over the person's head and then we're going to place one hand over the person's chin and then tilt the head back. And we're going to go ahead and put our mouth on top of the person's mouth. Create a seal, so make sure that there's no air coming out of the sides of the mouth. We're going to pinch their nose and we're going to give 2 slow breaths. When I do this, I want to look over, tilt my head a little bit to the side to make sure that I'm watching the chest rise, not the stomach rise. If I see the stomach rise, it's because the air is going into the stomach. But if I see the chest rise, that means that the breath is going into their lungs. And you can follow one breath every 5 seconds until the person can breathe on their own or until EMS arrives. Again, while you're waiting for naloxone to kick in, you can do the rescue breathing. You can start to open up the second dose of naloxone if you have it there, or maybe even a third or a fourth. Again, if there's no response within a 2 to 3 minutes, give a second dose of naloxone and begin rescue breathing. If no response, continue to do rescue breathing until paramedics arrive and take them over. Again, naloxone's only going to work if the individual has taken an opioid. Here's where I also pause and say, please stay with the person until help arrives or until the person comes to. Like I mentioned, Dr. John Roberts, who is the co-founder of Hero, retired police detective, he went down to Springfield and fought really hard to have the Good Samaritan law changed because a lot of the kids were being left in the front yards of their parents' house. They were left at the doors of the emergency rooms and not notifying anyone. So a lot of the kids did end up dying of an overdose because they were scared. They were scared that they're using drugs. They have drug paraphernalia on them. Now this person's dying next to them. They were just scared of facing legal problems. So he made it his mission to go down and say, hey, if you are helping somebody who's overdosing and dying from an opioid overdose and you have drugs on you, you're not going to get charged with any of this. It's in the Good Samaritan law. So you will not get charged for this. And it's Lisa's asking here on the chat, does the unit of naloxone have enough medication to administer 2 doses of more? So one box, let me see if I have, I'm here at the Hero offices. Let me get a box real quick and I'll be right back. But so one box, here's one box, right? One box has 2 doses, two 4 milligram doses. Here is one, this is one 4 milligram dose. So there's two of these in this box. So when you administer the first one, you're going to take this, right? And you're going to administer it, you're going to insert it on top of the, all the way in the nose. And then there's a plunger right here. It's now red, but this one is the one that we use for training purposes. You insert it and then you press the plunger. That's one 4 milligram dose. If the person doesn't come to, or the person's still not, you've assessed them again, it's been 2 minutes, person's still not saying anything, you're doing the sternal rub, and they're still not coming to, guess what? You grab the other one from the box, the second one of these, and you're going to insert it on the other side, and then press it, and then wait another 2 to 3 minutes. You can keep doing this again until the person comes to or until EMS arrives. You can keep, if you have 3 of these, guess what? 3 times 2 is 6. You have 6 4 milligram doses. So you can keep doing it and doing it and doing it again until the person comes to or the person or EMS arrives. You're welcome. But that's a great question. Thank you for saying that because a lot of times people think that one box is only one dose and this is sufficient and you're going to be fine and you could just spray them and leave, right? Oh, I'm going to administer naloxone. I'm going to spray them. They're good to go. I'm gone. No, it can, first of all, it may not be enough because unfortunately with fentanyl, it's a stronger opioid. So you may need multiple ones. And second of all, if I administer one, and if I leave the person by themselves, they can re-overdose. So we want to make sure that we stay with them until EMS arrives, until help arrives. But thank you, Lisa. Thank you for asking that. So after administration of naloxone, again, stay with the person as long as you can or until help arrives. That is very important. One, we want to make sure that we're telling them what happened, right? I think you overdosed. I gave you some naloxone. You're going to be okay. I called 911. Help is on their way, and just staying with them and letting them know is very, very beneficial. If the person is still unresponsive, lay them in a recovery position. I'll show you what that's like. And also, if they're confused, remember that the lack of oxygen going into their brain, they're not thinking correctly. They probably won't act correctly. And a lot of times, and this happened with me when I was Narcan, I remember that I woke up in an ambulance. I had four paramedics trying to calm me down, trying to hold me down. And I don't know where I was at. I don't know what happened. I don't know what they were doing to me, but I can't breathe. I feel like I'm drowning. My whole body hurts, right? Because I was given enough Narcan to throw me into withdrawal. So I went into withdrawal mode right away. So my whole body hurts. I'm anxious. Um, you know, I didn't know what was going on. It just everything, right? All at once, everything just started happening, and it's a very scary, traumatic situation to be in. Um, I always say it's traumatic on both ends. I've been Narcan and I've Narcan people. So I've had the experience of being Narcan, and that was my experience where it was a horrible experience. And I've also Narcan somebody, and when I did that, they wanted to punch me, right? Because now I threw them into full withdrawal mode. I probably ruined their high that they didn't want their high to be ruined, but guess what? I saved their lives. And I do this training for the CERT team, which is the Joliet Community Emergency Response Team, and the director there is a retired fire department um, officer. And he always tells me, I don't want them to wake up. I want to make sure that they're okay. I want to make sure that they're breathing fine, that their oxygenation is okay, that their blood pressure is okay. I want to make sure their pulse is okay. So he's checking all their vitals, right? And making sure they're good. But he doesn't want them to wake up because he says every time somebody wakes up from being Narcan, they get violent and they get defensive. And I can understand that, right? Because it's a traumatic experience. However, when I'm out in the street, I don't have the capacity to check their blood pressure. I don't have the capacity to check their O2 sats or their oxygenation. I don't have what the paramedics have. So if I Narcan you and I throw you in withdrawal mode right away, I'm sorry. And if you want to hit me, that's okay because I know that I saved your life. I will walk away or run away, whatever it is. But I'm okay with that because I have saved somebody's life, somebody's brother, somebody's dad, somebody's nephew, somebody's son, and I'll be okay with that. So that's my spiel on having that particular behavior after being Narcan. So again, we want to comfort the person and stay with them as long as we can. This is the recovery position right there. So you want to lay them on the side. Want to make sure that one of their hands is underneath their head and the knee stops the body from rolling onto the stomach. And we want to make sure we do that because we don't want, if there's anything in the lungs or anything that may potentially come up, we don't want them to aspirate or shut that airway again. So we want to make sure that we put them in this position so they're able to excrete anything that's in their bodies out, by mouth, by way of mouth to, and not choke on it. So what we want to do, we want to call 911. That's the first thing we want to do. We want to make sure that we are getting the professionals out there to help us to deal with the situation. We want to administer naloxone. We want to perform rescue breathing or CPR if trained, and if you're comfortable with rescue breathing. Place them in a recovery position if they're breathing. So now, I gave you all this naloxone and I see that you're breathing now. You may be even talking. We want to put them in the rescue position just so that we can get them comfortable, so that they don't aspirate, and so that if they do re-overdose, we have in a position that we're able to access that. Stay with the person until help arrives. The don'ts or the nays, I call the nays. Don't leave the person alone. Remember that they can re-overdose if we don't give enough naloxone, or they can come to but re-overdose again. So make sure that you stay with them. Do not put them in a cold shower or bath. This is something the movies created. You will give them shock, but it's not going to reverse the overdose. The only thing that reverses an overdose is Narcan. to try to make them vomit. We don't want to stick anything in their mouths. We don't want to we don't want to push something out further. Um, and don't give them anything to eat or drink. As a nurse that's worked the ER, the first thing that the doctor orders, even when the patient is coming via ambulance to the emergency room, is NPO, which means nothing by mouth. We don't know what that person has in their body. We don't know if they're having an allergic reaction to something. We don't know what's going on within them. And before they can assess what's going on, they need to not introduce anything else into their system. So nothing to eat or drink by mouth. And don't assume that they'll sleep it off because again, they can re-overdose. So here are some resources that we have. Again, we are the Tri-County R.O.S.C, which is Will, Grundy, and Kankakee County R.O.S.C. It's the recovery-oriented systems of care through Heart Life Ministries Recovery 180. We do partner up with different organizations, including Hero, to bring this education portion today. We also partner up with, the CERT team and Stepping Stones and Rosecrans and ECS. We have a lot of different partnerships. So if you want to become one of our partners, please shoot me an email. If you would like for this presentation to be brought to your organization, please send me an email. And See, this is the Heroin Epidemic Relief Organization. They are a non-for-profit organization. If you would like to donate, that's the website there. Please feel free to donate there. Here's my contact information. I will leave that up there, but does anybody have any questions? Okay. We have Lisa, no questions for me in the chat.
I don't think I have
Anything
any
that
questions, Maggie, but did want to say, did anybody on the call hear something they haven't heard before that was enlightening to you that Maggie in her presentation presented that you could think that is advantageous for people? Does anybody have any feedback?
For me, this is Gloria and at the Wayne Dean and Kankakee. For me, great job, Maggie. Great job. I've watched the naloxone presentations several times, and I think this is probably the best I've seen for you to give data in reference to the when some of these epidemics started. I think is important so that some of us can kind of see timelines and have a better understanding of how we got here. So great job with that. Very in-depth presentation. And yeah, so thank you. I am excited about helping to share this information so other people can join you on Tuesdays.
Thank you. Lisa here says, yes, I never knew that it would throw a person into instant withdrawal. That's powerful. Yeah. And I think this is one of the reasons why there's two in here, because we can start with there's another one called Cloxato, which also has two, but each one has 8 milligrams in it. So when you are giving 8 milligrams, it's like giving two of these right away. So right away, you can throw them into withdrawal mode. And this is why police officers, this is why different organizations like first responders like to have naloxone instead, because a 4 milligram, we can give one and okay, they start coming to and it's okay. We're not throwing them in withdrawal mode right away, right off the bat. But 8 milligrams, that's a little too much and it can't like automatically, and it's pretty traumatic to be doing that to somebody. So yes, that's one of the things that a lot of people don't think about, right? I can throw them into withdrawal. And then now I'm wondering why they want to punch me, right? Because you're like, I'm awake and what did you do to me? So, no, but I get it. The other thing that I failed to mention is that this is so harmless that it can be administered to pregnant women, it can be administered to children, and it can be administered to dogs. So a lot of the expired naloxone is given to the canine units because they carry it. Once this expires, you can still use it. It just won't be as potent. as regular, like non-expired naloxone. So what they do is that with the expired ones, they'll give it to the canine units because the DEA did mention that a couple of times they were doing some drug bust and the dogs inhaled fentanyl. And now the dogs are overdosing, right, and dying. So they have given naloxone to canine units, and canine units have been brought back because of naloxone. So yes,
Wow.
if you have expired naloxone, don't throw it away. Still use it. It just might take you more to reverse that overdose. You might just have to hit them up a couple more times than a regular one. But yes, I failed to. That's one of the things I always forget to say. But yes,
I did have one more thing. This is Gloria. The fact
yes,
that, because now when we're taking the naloxone around in the community, the fact that parents who are drug users or abusers, it's important for them to have this if they have children in the house because they could save their own child's life. And I never thought about the fact that a parent would be afraid to call the authorities to help their child because of their own activities. But if they could have this in their homes, that could help save their own child's life. So that's a very good point in a presentation. So thank you.
yeah, you're welcome. Okay, well,
Maggie,
yeah,
hi, this is Celeste. I have a question. Do you offer this training in other languages?
Spanish. I do. We did our first Spanish naloxone training not this Friday, but the Friday before that in Chicago. So we do. I'm working on being more fluent with it. I'm pretty fluent in Spanish, but when I try to the terminology is a little difficult sometimes, but I'm working on it. But yes, we do have this presentation in Spanish. Maybe that's something that we'll do one of these days, right, Nisha? We'll do an all Spanish virtual Narcan training maybe next month or the month
That would be
after that,
great. We
so
talked
that
about
people
that. So that was maybe that'll be our focus for November is to do it in all Spanish. That
all
would be great.
Spanish.
And we could just
Yes.
invite everyone. That's great.
Yeah.
Yes. Well, thank you all so much. Maggie, thank you so much. And we will definitely be back next month, same time, same station in Espanol. Have a
All
good day,
right.
everybody.
Thank you.